Robin?
Yes, I'm here. Hello?
Yeah,
can you hear me?
You can tell me when you're ready.
I am here and ready to go.
You can begin.
Well, maybe
Right,
maybe just let me just introduce. So Jesse Sullivan, I'm the medical director at PSYCKES, and I didn't notice do we have Jamara or Tina on this call? I don't know. There, say hello. No, okay. Then I'll just welcome people, and so I just want to remind people that this is jointly sponsored by all in the Hudson Valley, and that we're to figure out how we can use whatever resources we can to identify patients with psychotic so that they receive appropriate. And today, Robin Turner from the Public Consulting Group and Val Doan from our office have put together a presentation on how to use reports available on PSYCKES for this purpose. So, further, I'll turn it over to them, and then just remind people that put us on hold. You can mute yourself if you want, but don't put us on hold, and that we are recording, so keep that in mind. So, Robin, if you would like to begin.
Thank you. So, welcome everybody. Again, this is Robin Kerner. I am with the Public Consulting Group, PCG, and I'm hearing a lot of noise. I'm wondering if the organizers want to mute all the lines except for mine.
Sure. It is possible. Okay. It looks like we're getting some help here, some technical help to do that.
Right. I'll wait.
Can you? Yeah, we're going to mute all and then unmute Robin. That's a much faster way to do it, right? Okay, Robin, can you hear us?
Yes,
See if we can hear
I
you.
see. Yep, I see that I'm unmuted. Everybody can hear me, I hope. So I'll just continue again and welcome everybody to the webinar, and I'm really pleased to be here today to help support this PPS and the rollout of PSYCKES. We can get to the first slide, please.
Next one. Yes.
Great. So in this webinar, we're going to cover, as you can see, a little bit of the background about PSYCKES, and then go into, I'm going to toss it to Tao, who's going to cover how you can actually use PSYCKES through a couple of different reports. And then we'll talk about some of the additional resources. This is meant to be sort of somewhat of a high-level overview, though we will get into some of the nuts and bolts about PSYCKES. There's a lot more training that's available, both online. There'll be live webinars, and also we have resources available to do some more personalized training as it's needed. Next slide, please. So again, all of the information that we're going to be presenting here today is available on the PSYCKES website for you to dig in a little bit deeper on your own. So starting very basic for those of you on the phone, and I think there's probably many people on the call who don't even know what PSYCKES is. So just to explain the alphabet soup of the acronym, it stands for the Psychiatric Services and Clinical Knowledge Enhancement System. And it was developed by the New York State Office of Mental Health, OMH, and it's been up and running for several years now. Originally started as part of a quality improvement initiative throughout the state, and then over the years, the data had been released to providers so that we could use it for treatment purposes as well as for quality improvement. Next slide. And it contains some very robust data in terms of quality indicators. There are many different levels of which you can drill down, and you can actually see performance data across the state, even beyond your own individual program, so you can easily see where your performance falls compared to others in the state and in the region. The data in PSYCKES are claims-based, and they're updated on a monthly basis, and your clinical information gets fed into the system weekly. So, it's fairly up-to-date as claims-based data goes. It's very easy to see the clients in your caseload and at your program who are hitting the quality flags, as they're called. And when somebody has a quality flag, you can access a great deal of information without any client consent. But client consent is needed to view the protected PHI, which we know is substance use, HIV, genetics, and reproductive family planning data. Next slide. So there's a lot, as I said, it's a very robust database. There's now over 6 million New York State Medicaid enrollees, and hopefully more through the DSRIP efforts as we're reaching out to the uninsured and helping connect them and get them insured in Medicaid. It covers fee-for-service, managed Medicaid, as well as the dual eligibles. And in PSYCKES, the population is defined as a behavioral health population, but that's a pretty broad definition of behavioral health, and it's one of the following: either they have had a psychiatric or substance use service within a certain time period, usually 18 months, they have a psychiatric or substance use diagnosis, or they're prescribed a psychotropic medication. And all of this is as defined in the database, and more information is available in the application to drill this down. But the point here is that there's a lot of patients and clinical information and quality information available for a very, very large population. And it provides 5 years of claims-based look-back data, and it's all of the data. It's general medical, behavioral health, inpatient, outpatient, residential, emergency, pharmacy, dental, transportation. Anything that led to a Medicaid claim being dropped is going to show up in PSYCKES. And once either a client hits a quality flag or you have client consent to access the data, you can see all of it, not just your own provider information. So this is, very important as you're thinking about, we all hear, and I come from the provider community before moving into this role with DSRIP, so we all had a really hard time tracking our clients through the system because they would visit lots of different providers. So this is a way where all of the information is gathered in one place as part of the clinical summary, which we'll be demonstrating a little bit later in the webinar. Next slide, please. So now the big question, who can access all of this amazing data? Well, the good news is that access is available to a very broad network of providers and partners. Any New York State OMH or OASIS licensed provider, as well as FQHCs, can currently get access to the system, and so that covers, as you can see the list here, this very broad range of providers and government agencies that have access into PSYCKES. Next slide. I'm not going to read them through, but you can take a look at these after the presentation. So now that you've been excited about all of this amazing data, your next question hopefully is, well, how can I get access? So again, the good news is that many of the agencies that are working with the PPS as well, throughout the system have already, their agencies probably already have data and have access to the data. And in order to get individual providers access, there's a pretty simple process that needs to be followed, which we'll talk about a little bit later in the presentation. But as you can imagine, this is a highly protected database, and so it does require that users have what's called a soft token, which is a computer-based identification system that's unique to each individual user at an agency. And so it takes a double authentication to get into the data system. And so each PSYCKES user has an OMH ID and a soft token, and then a password that gets generated every 60 seconds to ensure that the data maintains its high level of confidentiality and protection. And we just want to reiterate, as with I'm sure is the security policy at your agency, you can never share your user ID or your password information specifically for PSYCKES, so I imagine also at your home agency as well. It's a violation of policy. These are unique identifiers, and they're not to be shared throughout the agency. Next slide, please. So again, continuing, so how can you get access? So what we'd like to suggest is that each provider or partner here on the call who would like to have access for staff, that you identify a PSYCKES lead at your agency, and that lead is going to liaison with your agency security manager and facilitate all of the staff access in a centralized manner. If you do not know who your security manager is at your agency, the PPS, along with myself, will be able to assist you with that. It's a very simple process. And then once your PPS, your agency lead has the list together of all the potential PSYCKES users at your agency, they'll just need to gather these 3 pieces of information that are listed here about just your name, your date of birth, your gender, your email address, and if you already have one, your OMH ID, or else one will be generated automatically as part of the process. And your security manager enters that into the system and begins the process for access. It only takes usually a couple of weeks once the information is in the system, and it's often quicker than that. Next slide.
So maybe we should, this is Jessie, so before we get into these reports, maybe we should pause to see if there are questions. And I actually have unmute people, but I have a question to kick it off, Robin, which is that when you had the list of who had access, I noticed that FQHCs were not on that list, and it's my understanding that they're added to the list, or
I did put they are on that slide. It says FQHCs. I'm not sure what you're referring to on the slide that I presented here in the deck. It said OMH and OASIS providers and FQHCs.
Oh, I'm sorry.
Yeah,
Okay.
they weren't listed by bullet. It was the header.
Okay. Oh, all right. Okay, good. And well, maybe a follow-up would be: are there any other groups that weren't on that list that are being considered as possibly having access? So, other medical groups that see Medicaid that aren't. I'm just asking. I don't know.
Such as like a freestanding primary care practice that's not affiliated with a hospital?
Yes.
Yeah, to my knowledge, nobody, that has not been formally requested, so I don't think that's being worked on. If it's part of DSRIP and that's a partner that a PPS wants to promote to get access, we can certainly take that back and discuss that with the PSYCKES team. But right now, it's limited to, but that being said, if that medical practice has an affiliation with a hospital, they could be granted access, through that parent hospital. There's ways that we can discuss offline, creative ways in the interim to help everybody who would benefit from access to have that access.
Okay. Great. Can we unmute everyone for a minute to see if there are any other questions? Oh, someone wrote in a question.
I see. Yeah, there's some. I was going to suggest, given the volume of folks on the line, it might be best if people type in or raise their hand so you can call on them.
Or have a question.
Okay, so someone asked us to mute people, but I think everyone is muted. Right?
Sorry, I was just joining.
Hi, this is Taylor from Middletown Community Health Center. Can you guys hear me?
Yes, we can.
Okay, so question, and I'm sure a lot of people are thinking this, but are you guys working with the HIE, the RIO? Like, is this data going to be in part of the HIE or no?
So, Robin, Robin's not officially representing the PSYCKES, but my understanding is no. That it's a separate portal.
And is this? I can't remember, Jessie, from our Hudson days. Is this like a individual lookup? So you have to look up by person?
Well, it is an individual lookup, but what we're going to demonstrate is there are some reports. So that's what we're going to.
Okay, perfect.
Yeah.
Okay.
Any other questions?
I see a question was typed in here. It says, So when you say that there are claims data in PSYCKES, how detailed is that? Is there specific clinical data, such as medications, et cetera? And I think the answer to that is yes, and it's going to be demonstrated shortly. So you'll see everything that one can get in the clinical summary.
Okay, great. Okay, so I think
Well, she didn't go through this slide.
is this you or is this Robin? I didn't.
This is Robin.
Oh, Robin, sorry. This is. Oh, go back.
So there's, do you want me to cover this slide?
Yes, please.
So there's two.
Muted Robin. You got to mute everyone and unmute Robin. And then unmute Robin. Okay, Robin, we just unmuted you.
Right. Yep, thank you. I saw it here. I get it indicated here on my computer, so perfect. Thank you. So there's two ways that we're going to demonstrate here today how providers can access recipients who are hitting the quality indicator flags. And again, I realize we've used this term QI flags, and I haven't actually explained what that means. So basically, there are quality indicators that are pre-programmed into PSYCKES as part of the statewide effort to improve care of our patients in the behavioral health system. So if an individual is determined to fall as, outside of what would be a quality indicator, and you'll see the list of the quality indicators in a moment, they get flagged as an outlier and somebody who should be receiving more targeted outreach and care to address the care gaps. So there are two ways that you can see who's hitting a particular quality flag, and one is through something called My QI reports, and those are sort of canned, built-in reports that have been developed by OMH over the years as part of their learning collaboratives and part of popular request. And many of those relate to DSRIP metrics, and it's very much sort of one-touch report generation. So some people really like going in there and using those canned reports. And the other way is something called recipient search, where a user can select a variety of filters, so you can do a bit more customized searching for individuals that are meeting the quality indicators or not meeting the quality indicators and are therefore flagged. And Todd's going to demonstrate both of those types of reports. Both of those reports will, and any reports that are accessed in PSYCKES can be exported in Excel so that you can interface them with any of your own data collection systems or data analysis. And they also can be downloaded to PDF, which are often a little bit easier to read. So depending how you're thinking of using the reports downstream, you can figure out which format might make sense for you. And it allows you to drill down, and as we've heard from the questions, there seems to be interest, to drill down to the clinical data at a patient individual level using either of these report generation techniques. And as I said earlier, the data, the clinical data in these reports are updated on a weekly basis. So I think we'll turn it over now. Yes.
Okay, so and Sal, I can't remember if this is in your presentation or not, so pardon me if it is. But I think what Sal's going to demonstrate is anyone can see the identified data for their own patients. And I just wanted to redefine what one's own patient is.
Oh, anyone that you've served.
In what period of time?
What about
18 months.
18 months.
Or if an individual has given consent, you get data for 3 years past your last date of service.
Okay, great.
So good afternoon, everyone. I'm Sal, and I'm a Senior Research Analyst here at the Center for Regional Healthcare Innovation at WMC Health PPS. And I will show you a couple of ways to search for search PSYCKES to pull reports of patients on antipsychotic medications. As Robin had mentioned, there are two ways for you to do this. The so-called CAN reports can be found under the My QI report. There are two basically relevant indicator sets. The first one is the general medical health indicator set, and the second one is the behavioral health core improvement measure indicator set. So this is the, once you sign into Psyche, this is your landing page, and this is my QI report, and you can see that by seeing the red highlight here, it says my QI report. And note the two indicators that, as I mentioned before, the behavioral health core innovation improvement measure and the general mental health medical health measure on the left here. Up here, it shows you the information you can view by report only, by graph only, or by both. Just to simplify the view going forward, I would just do the report only.
Read the question out.
Someone is asking, can you distinguish what level of reports can be accessed if the patient is in your program without specific patient consent? Also, again, the timelines for the various levels of consent.
Okay, so I believe
I would suggest maybe we hold that question to the end because we sort of cover it, and if it's not covered, I'll circle back and answer this at the end.
Fair enough.
Okay, thanks. So of the two indicator sets, the first one is the general medical health. If you are interested in finding the full sample of the adult patient who your organization serves, who has at least 2 prescriptions for an antipsychotic medication, regardless of diagnosis, who did not have both the blood lipid test and the HbA1c test in the past 12 months, this is where you go in. So here you can see the indicator set is general medical health, and you look for the top indicator, which is the no metabolic monitoring on antipsychotic. So in this example, for Westchester Medical Center, as of November 1st of 2016, WMC had 823 patients flagged with this quality indicator. This is the full sample.
So that means 823 patients who were missing one or both of those screenings.
Exactly. Adult patients, yes.
Adults.
Right. Yes. Now, if you are interested in not the full sample, but you also want to see just by the core measure or the HEDIS measure, which is the DSRIP metric, then you go into the other, the BH core improvement measure indicator set. And again, these are for adults who are diagnosed with both schizophrenia and diabetes who did not have both the HbA1c and the LDL-C test in the past 12 months. So in this example, here it says BH core improvement measure. Here is the indicator, no diabetes monitoring. And you look for the adult, look across here, and here you see 41. So in this example, this is the DSRIP metric. Out of the 823 total from the previous slide, WMC had 41 patients who were flagged for this core measure.
So can we unmute everyone for a second? Because I saw Amy's on the call, and I want to say something. So Amy, yeah, unmute everyone. Great. Okay. So after our last practice call, we were looking and we found this, and so we talked about wanting to do workflow that would deliver perfect care. And so for me, the workflow that would deliver perfect care for WMC is that we have 823 patients who are on antipsychotics and haven't had both the screening. So that would be our work. So we would develop a workflow to try and bring that number down to improve our ability to deliver compliant care. But we were talking the other day about if we can't develop data sources to figure out which of the tests are missing, and when do we get to the point where we're just going to order the tests that are missing without knowing if they've been done somewhere else. I think that this is when we might want to go to this and say, look, before we just order this, these are the patients we're desperate about. We know they fall in the measure, they meet the age criteria, they have the diagnoses, they haven't been screened in the appropriate time period. So I'm kind of thinking these would be the 41 where if you can't develop workflow to find out if they've had the test, you just order the test. And the others, we maybe don't go there yet. But I'm interested in your thoughts.
So Jesse, this is Amy. I'm sitting with the team that was on the previous call with you, and that's really helpful on this particular screen. One of our team members was just calling that out. So that seems like a much better solution than massive ordering of tests. And so if we can drill down to who's at risk on this screen, that's a good starting place. We're also thinking that once we get some flow on this, then it's not going to be giant numbers on a regular basis. And as we improve the integration that we're all working on with primary care, we'll start to find the other solutions and other workflows to get those results.
I also felt like this was a much, like to have both reports. It lets you know how big the problem is altogether, but it lets you focus your desperate measures on 41 people. Yeah, on 41 people, right.
So then once you get to this page, you can drill into this. Since we're already in the core HEDIS improvement measure, I'll just go forward from here. But the format is the same for both indicator sets. So here, once I drill into the no diabetes monitoring under the core HEDIS improvement, you can see it up here. Your kind of summary of your filter. So here is the core improvement measure, and then indicators no diabetes monitoring, shown here by the red arrow. You get to this recipient report landing page. And here's the de-identified version because, you know, information. But here you can see from this report you can get the recipient, you can get the Medicaid ID number, the day of birth, and then the quality flags associated with each patient, the medication, for example this one, and then the most recent case, outpatient attending physician, and when it was the last time the clinical summary was viewed. And up here I want to bring your attention to this is where you can export this report out either as PDF or as Excel file as Robin has mentioned. And then finally, for you to see the individual patient clinical summary, then you can click on the name of the patient, and then that will bring you to the clinical summary of that.
Before we go on, so at this level, even though we've now identified the patients by name and we know who they saw, we still don't know which test they're missing. So we know that these patients are missing one or the other or both screening tests, but we do not know which one. It's just one at this level.
Right. So again, the format is the same. So instead of recipient, this is attending. Instead of the core, I want to use this. So here's the attending. Here's the attending view. So here you would see the attendant's name, the license numbers, and then the number of patients with the QI flag associated with that attending physician. So this is a very useful report because that can assist staff with the clinical outreach efforts as well as the continuous quality improvement.
So I think maybe I just need to say that we put those blue boxes here. So when you get this report, it doesn't have big blue boxes. It has names. But we felt because we didn't, you know, we're at Westchester Medical Center. We're in one office of Westchester Medical Center. We didn't have the permission of the doctors whose names were there to show their names. So that's why we blocked out their names. It's not PHI, but...
So basically, this is how you would pull this report by the CAN report through my QI report. Now, the other option is to pull.
So before we move to recipients, maybe we should open the line for a minute to see if people have questions. So we open the line. Does anyone have a question?
Can you hear me? It's Andrew.
Yes.
Oh, good. From the attending, can you click from the attending and see the patients that are, that are numerically identified in that far column? Can you see those 18 people? If you click on from this attending screen?
I believe you can, but I don't.
Yes, that's exactly what happens. When you click on that number, you'll see that attending patient, and that can be exported, to that and sent to that attending for follow-up.
Great.
Yeah, it's a pretty effective tool at at staff meetings to put up everybody's numbers without the boxes.
Right, without the boxes. Right, and someone says, how can you determine if monitoring was done? So we know here that one of the monitoring is missing, but that's what Sal's about to go into, is how you would figure out which test was actually missing, is in the other report.
In the report, yeah.
Yeah, so that's where we're going now.
Okay, so this is basically the CAN report. So next is, well, the other option is the recipient search, which allows for customizable filters. So this, again, back to the landing page. So instead of going to my QI report, as you can see before, you go into the recipient search. So you select recipient search here, and again, here is the view where which information you want. So once you click into the recipient search, if you are interested in getting the full sample, then you would go to, you would search for client flag with no metabolic monitoring on antipsychotic, highlighted here. Hard to see, but it's there. And then the recipient search allows you for other filter options if you so desire. Remember, for the CAN report, for example, you can only see adults 18 to 64. You may want to see the, the children population. So here you can enter in the age range from 0 to 17, for example. You can filter by gender, by HOP status, by OT status, population, managed care plan name, alerts and incidents like suicide, ideation, or attempts, etc. So here it gives you just more options to filter out if you were so desired. I also want you to notice the data as of date. This one shows October 1st of 2016. As of today, Psyche has data for November 1st of 2016. So there's a lag about 2 months. And then on this side, you also have the different data time frames. So you have the option of looking at the past 6 months, 9 months, or the past year, 2 years, 3 years, etc. And then finally, the maximum number of rows to be displayed is default at 50, which is actually very small. So you may want to increase that to about 10,000 or 50,000, however, and then you click search. So that was the recipient search for the full sample. Again, if you're only interested in the DSRIP metric or the qual measure, you have the other option. You can now go to the no diabetes monitoring under the quality flag drop-down. So if you select that, then you will pull that report. Or as Andrew was asking and Jesse mentioned, if you want to break the cohorts out to 2 separate cohorts, now you just want to see those who on antipsychotic but without the glucose HbA1c test, you can select this quality indicator as the measure, or you can just select those on antipsychotic without the LDL-C testing. And then you can search it that way.
So at this point, as far as our understanding is that the only way to know which test patients are missing would be to pull the file for the patients missing the LDL and then pull a separate file for the patients missing glucose. And then you could work those as 2 separate lists, or you can combine the 2 Excel files and look at them together. I think it might be a request to Psyches from the PPSs to have a report where you could pull one report but see which test was missing, but that doesn't exist right now.
That's what I meant. So here are some of the examples of some of the results. So in this case, I was looking for adults between 18 to 64 with no metabolic monitoring and on antipsychotic for Westchester Medical Center, and the report shows that I have 1,019 recipients who met these criteria. And the red arrows here show you basically the filter summary, and then you have, again, similarly, you see the names, the Medicaid ID number. Here you have all the different quality flags, the managed care plan name, and then the current PHI access. So if your patient has one of those QI flags, then you will be able to pull their clinical summary information. If they don't, then you will need a special consent. That's
that's the point. So another way of saying that is the patients who don't have any problems aren't on this list. So you can't tell you can tell how bad a job you're doing, but you can't tell how good a job you're doing.
Yes, you can. Actually, you can, because you have the denominator. You have the denominator of, so you see your numerator. The numerator are the problematic patients, and your denominator is your total population. So you just subtract.
See where the total population is. Where's the total population?
I actually can't see this screen large enough, but, or you can also just do a recipient search without the quality flag listed.
Right.
So and you could see numbers.
You just say all patients on antipsychotics, right, and you get the number.
Right.
Okay,
right.
Good. Good.
Okay. And again, you can export these reports out. So if you export in PDF, this is what the form will look like. And the use information is tracked at the bottom of each PDF. This has to do with the confidentiality of information, and you make sure that they track who was the one that printed the information. This is the results in Excel. Again, name, Medicare ID number, gender, etc., and then the quality flags. Now, someone pointed out that this is a text file, a text string in an Excel file. So, so Robin tried this out, and it worked, and I've looked at it, and it's also worked. You can use Excel's formula to separate this text string out separately into different columns, so you can separate them out into different quality flags if you so desire.
And that, by the way, is how you can see which test is missing.
Exactly. So this is where you can see.
Got it. Okay.
Yeah.
All right.
Yeah. And finally, this is the clinical summary, which gives you information at the individual level. So here you can see the client's name and their address and contact information, whether they are Medicaid or Medicare or dual, managed care plan, HOP status. There also current care coordination contact information. For example, who you should contact at the health home. You also see the alerts and incidents. For example, the number of you know, the details of the alerts, where it happened, etc. You can also see medication, outpatient visits. You can see hospital, ER, dental, vision, lab, and pathology, though it won't show you the results of the lab. You're going to see medical equipment and transportation services. So all of this you can see at the individual patient level. And so that is basically recipient search.
So Robin's saying that there's files available that don't seem to be on file. Do I know that?
That's because just on the computer, when we started, we have to download it on here on the computer. She sent it to me.
Okay. So there's some additional PSYCKES training and information resources. There are a couple of webinars coming up, and you can attend to either one of them for PPS providers and partners. One is on February 9th from 10 to 11 a.m. or on February 13th from 12 to 11 p.m. And then finally, you can visit PSYCKES website with the link below for more resources and training materials and recorded webinars. So any questions?
Do you want to tell people
this is Amy. This is Amy of the Access team. I have a question. We're this is great progress. Thank you. We've learned a lot, and I'm pretty shocked with the results as we're running some of our own numbers and seeing how many people don't have this monitoring and comparing it to state averages. I can see why these are important measures because our state averages are pretty poor. And I wanted to ask clinically about children, the fact that they're not targeted. Is it still recommended for children? Because our numbers and the state numbers for the children on antipsychotics are considerably worse than the adults.
So let's turn, I don't know the answer. Andrew, can we turf that question to the work group? And you know what, maybe we should have you announce to this group what that work group is and what your task is. Oh, we have to unmute Andrew if he's,
No.
oh, did we lose him? Maybe he's
Hold on. How
Ah.
am I? Can you hear me now?
Yes, we can hear you.
Okay, Verizon is definitely better than AT&T. So I guess there are two issues. Yes, there's certainly an indication for following these numbers in adolescence on antipsychotics. I don't think I need a child psychiatrist to tell me that. And it's probably good practice to even follow it in children, because there is a risk for diabetes and weight gain in these age groups on these medications, a significant risk. So that answers that specific question. In terms of what we're doing in our work group that's meeting on Thursday, our goal is to come up with guidelines for all the types of monitoring that we think are good practice for patients on antipsychotics. So that would, of course, be metabolic monitoring for diabetes and lipids. There is some indication for cardiac monitoring, and we want to figure out how we should structure that. And there may even be indication for endocrinological monitoring, because some of the medications do affect prolactin and bone density. So that we're convening, and that group consists of psychiatrists and also endocrinologists and primary care providers. So I think we'll have a lively discussion. There are some guidelines out there already, and I think our job will be to take those guidelines and enhance them into one usable document.
Great. Yeah, so thanks so much. So Amy, so it sounds like Andrew says the answer is yes, it's worth monitoring, and we'll have the formal guidelines from the work group in the next period.
Terrific, thank you.
Claims data.
So there's a question here. Does someone want to read it?
Well, this is a response. Robin wanted to remind everyone that you can figure out a way to identify the individuals through recipient search who have received a service during the reporting period and then export it to Excel. I don't see why not. So the answer is yes. Except with the lagging claims data and the need to report the engagement in a timely manner. It may not work.
Well, yeah, I mean, there's always a lag. Yeah, there's going to be a little bit of missing data, but a month is 2 months. You said 2 months. Yeah, that's not too bad.
But the number we can focus on is very small, even for WMCs of 50 people,
Yeah.
out of 1,000 people.
Yeah, out of 1,000, right? Well, we're ahead of schedule by a few minutes. Any other questions or thoughts?
I like that they're asking.
Not that I know.
Good question, yeah.
Yeah, I see the question. Is there a way to use the data from PSYCKES to report actively engaged patients?
That's what I was answering. That's what I answered. That was the answer that my answer that I typed.
Right. Well, for us,
Oh.
the actively engaged patient requirements fall in different measures, so the answer would be no.
I actually have another comment, if you can hear me.
Yes, we can.
Yes, it just has to do with, I haven't looked at the PSYCKES system, haven't handled it myself in a couple of years, but one of the issues that might come up is if the first filter is people taking antipsychotics, when does your antipsychotic sunset? So if I prescribe it in January and I look in June, is that person still scored as being on an antipsychotic or not? I guess we'd have to test out those kinds of questions, or maybe someone knows.
Oh, that's a good question. Robin, do you know offhand what's the definition of on an antipsychotic?
I don't know it offhand. I'd have to go back. I mean, it's all, when you're on the website, they have pretty detailed definitions of each of the measures, and so that's likely available on the PSYCKES website. I mean, we can certainly spend time and figure it out if it's not already there, or we can, the PPS has a training with the PSYCKES team in a couple of weeks, and we can certainly ask that question if we can't find it ourselves.
Yeah,
but all the definitions are pretty specific.
Right, so we included here in the appendix for the slide deck is the PSYCKES quality flag definitions. Some of them are missing, so we're working with Robin to update this list, but currently this is what is available on PSYCKES. And so, for example, we were looking at the core measure. So here, the percentage of children or adults, right, with at least 2 prescriptions for antipsychotic medication at any time during the past 12 months who did not have both the tests. So some of the definitions pretty straightforward, some a little bit quirky, but
so let's see. So that's the core definition. Let's see what the definition is just for the more general report. People with the no monitoring, right? It's also past 12 months.
Yeah. So
yeah. Okay. So Andrew, there's the answer. So in this case, the prescription has to have been within 12 months. So whether or not you agree with that, if it should be less, more, but it's at least we know what it is. It's 12 months.
Oh, and it looks like it's have received at least 2 prescriptions during that 12-month period. Right.
Yeah.
Okay. So that again, you still have the issue of you start people on medication and they take it for a month or 2, and then you decide to discontinue it. Then a few months later, you try something else. You discontinue it. So if anything, this will be more sensitive than specific, so you'll have greater inclusion of, you'll have false positives, and that's easier than false negatives.
Yep.
You'll still have some false positives.
Yeah, good point.
I just want to add something with regards to the definitions. So this appendix is very helpful. I just want to also let people know that when you're in the application, there's a lot of live information. As you hover over, the hyperlinks for the indicators, the definitions will pop up. So they try to minimize the need to go back and forth between PDFs and the application live. So there's a lot that you can find out while you're actually in there, so you can make live decisions about what reports you might be interested in or a definition.
Right. And I see someone just asked a question, is there a way in PSYCKES to see if a client has seen their primary care physician? So that would be in the patient profile screen, I guess. And I don't remember if there was anything about primary care.
So there'll be listings for medical providers. There also are quality flags about physicals, I believe. As you go through the general medical health, there are different kinds of flags there. But a primary care physician with just the Medicaid claim is just a medical outpatient provider, so you might not necessarily be able to tell from the clinical summary that it was a PCP. But I do think there's a flag for no annual physical.
Robin, do you know if PSYCKES is considering displaying the Medicaid managed care assigned PCP for those who have one?
I know that when you do the QI report, you can see the managed care company. Whether they show the actual assigned PCP, I'm not sure. I'd have to look in the application and see if that's been added.
So I think that would be an ask that we might have. I mean, that's come up several times, that for the PCPs, it's hard to know who the behavioral health provider is, but there's a consent issue there. But for the behavioral health providers, it would seem that knowing who the assigned PCP is doesn't require consent and could be, and it's known, it's data that the state has, so PSYCKES could display that data. That would be helpful.
Yeah, so when the PPS has their meeting with PSYCKES in a couple of weeks, that could be a good thing to ask. And in general, along the lines of what I was saying before about, hyperlinks and sort of a lot of information, really encourage everybody, once you get access, to play around in there and take a look at different reports. You can't break it, so, it's really just getting comfortable with hitting different links, looking at reports, slicing and dicing, seeing what you can do in there. There's so much information.
Okay, well, we're 10 minutes early, but unless there's another question, I think we're done. Any last thoughts?
Someone did, and
A patient.
it also shows you if patient is enrolled in a health home.
Yeah, that we saw that. That was the that was good. That, yeah.
Or patient.
Okay, well, thank you, everybody. And particularly thanks to Sal and Robin, because they actually spent quite a bit of time, and Anna, going back and forth on this. So we really, and Andrew, good luck with your meeting with the other docs at the end of the week. We're looking forward to your guidelines.
Thank you.
Rob,
Thank you.
Take care, everybody.
Thanks, everybody.
Thank you,
Bye.
everybody.